in the interest of cross-collaboration, I wanted to show you some of the challenges that we deal with, and perhaps this would be able to help us both as we kind of try to solve this disease. So I have a disclosure from GlaxoSmithKline. This is a pat on the back to everybody here because this is a clinical trial that we're starting in Zaria in 2024. So they provided $2.4 million of funding to facilitate this clinical trial. So what I want to do today is to highlight some specific challenges to treating patients with cervical cancer in Florida, and then to review some special considerations for this population. So within the University of Miami, there are two main hospitals where we practice, and they're very different. So the University of Miami Hospital, Sylvester Comprehensive Cancer Center, is the private hospital. So at this facility, we see patients who have insurance. Now, insurance could be workplace-provided insurance. This could be military-provided insurance, or this could be some government insurance, so specifically Medicare and some forms of Medicaid. Now, when we talk about private insurance and when we talk about Medicaid, there's a huge spectrum of things that are funded. And there are very different levels of things called deductibles, which is the amount of money that a patient has to pay before their insurance will start to kick in. But everybody at Sylvester has insurance. At Jackson Memorial Hospital, not everybody has insurance. And so while we do take some Medicaid plans and some private insurance plans over there, most of the patients are what we would consider unfunded. Now, the county has come up with a way to provide medical care for these patients, and they call it obtaining the Jackson card. And so, several decades ago, essentially what the city did is mandate a specific tax on everything that is sold and every transaction within Miami-Dade County. And it's something like 0.01 cents that goes into the public health trust. And so what this does is it helps facilitate medical care, pay staff, obtain supplies. And there are various levels of the Jackson card, and a lot of it depends on your personal level of funding and whether or not you're a citizen of the United States. So there is a Jackson card that is permitted for patients who have a visitor's visa that has expired, and then the county will cover it. So oftentimes what we run into is people who come on a visitor's visa or a tourist visa, which is good for 90 days, and then they have a medical issue, and then we're really kind of strapped to do anything for them, and they have to pay completely out of pocket. So you can see the patients who we treat at both of these facilities go from those who are completely unfunded with very little money to super VIP people with excellent insurance who can pay probably out of pocket for those things. And so we all know cervical cancer treatment depends on the stage. That's why we emphasize screening. We can do surgery for localized disease to the cervix, so typically anything that's less than 4 centimeters in cervical confined, we can still operate on. For those who've got locally advanced disease, meaning disease that was spread to the lymph nodes, extended to the vagina or into the perinatrial, which is lateral tissue adjacent to the cervix, we need to do chemoradiation. And then when somebody has distant metastatic disease, based on a publication from the New England Journal of Medicine about 1 year ago, we're not just involving chemotherapy with cisplatin and paclitaxel, but we're also using bevacizumab, which is an anti-angiogenic biotherapy, and then pembrolizumab, which is an immunotherapy drug. So one of the big things is how long does it take from diagnosis to treatment initiation? A lot of the things that we get into here are what are the financial burdens, what are the scheduling burdens. These are actually data that were taken from our institutions done by one of our fellows, Dr. Roy. And so we wanted to see what specific patient-level factors contributed to delays in diagnosis. And so you can see from up here, people who had older age had a higher level of delayed diagnosis. People who had their diagnosis at what's called an outside hospital. So outside hospital was someplace that's not Jackson or UM. And so in those cases, the patient had their biopsy and then needed to work their way down to us in some fashion. So that introduces a lot of delay. The treating institution did not matter, so that's good for us, right? So whether you're at the public hospital or the private hospital, the treatment initiation was the same. Interestingly, race and ethnicity were very important. We use non-Hispanic white as a reference group. Patients who were Hispanic white, so predominantly people who were coming from the Caribbean and Latin America, had a faster initiation of treatment. And I think a lot of that is reflective of the population in Miami-Dade County. So just as an aside briefly, Miami-Dade's an incredibly diverse community. Only 11% of the population in Miami-Dade County is white. More than 50% of the people speak a language other than English in their household, predominantly Spanish. But we've got significant representation from the Caribbean and from Central and South America. And so because of that, we've got a significantly diverse community. And so when we move, however, on to African Americans or Afro-Caribbeans, we see some variation. So people who were born in the United States who identify as Black had treatment delayed. However, those who are Afro-Caribbean or Afro-Latina did not have that kind of treatment delay. There's some interesting data from within Miami-Dade that actually suggests that the immigrants engage much more quickly with the health system in terms of obtaining their insurance, even if it's county insurance, relative to those who are U.S. born. Language was also very interesting. So Spanish was protected, reflective of the Hispanic population. I think that may also be because many of the employees speak Spanish. I mean, even I can speak Spanish now just because of necessity. Those who speak Haitian Creole, however, had a substantial delay. And while there is a not insignificant amount of people who speak Creole, it's not that many. And then insurance status, unsurprisingly, those people who were self-pay had a much longer treatment delay. When people had stage 1B3 to 4A, they actually got treated faster. Those are people who were getting chemoradiation. That's likely due to the overlap of the radiation oncology and GYN oncology teams caring for the patient. If people needed imaging, that prolonged the time for treatment initiation. So to get a PET CT, while we do have access, that can sometimes take up to a month at the county hospital, which introduces substantial delay. MRI pelvis takes a couple of weeks. If somebody needs an exam under anesthesia for biopsies or stage examination, depending on scheduling, that can be a couple-week delay. And then depending on the specific treatment with clinical trials, understanding all of the logistics that go into that can introduce some subsequent delay as well. More criteria is really just kind of an assessment of multiple risk factors, and that actually seems to be protected, likely reflective of higher stage disease. So things that are also important that are independent of patient level or individual characteristics is what's happening with the disease. We know that when people have advanced disease, it spreads to the pelvic sidewall laterally. It extends back posteriorly into the sacral nerve root plexus, and so it's very common for these people to present with significant amounts of debilitating pain in their lower back, in their pelvis, in their buttocks, and radiating down the leg, specifically if there's nerve involvement. And oftentimes, we need to be able to control that before somebody can sit in a chair to get chemotherapy or lie on the radiation table to have their simulation performed. Hemorrhage is a huge problem. In fact, when we're looking at things that are associated with death early on for people with advanced cervical cancer, it's hemorrhage. There is substantial overgrowth of very aberrant blood vessels. Anybody who's taken a biopsy of a cervical cancer knows that you need to hold pressure on that for a long, long time. And if you've got a patient who requires vaginal packing, or in some cases uterine artery embolization, or quick dose of palliative radiation to arrest the bleeding, that will introduce subsequent delays in therapy. We know that urinary tract obstruction is a common thing. Again, because the ureters anatomically go right underneath the uterine arteries. Once you start to see that lateralization of the tumor, you can have complete ureteral obstruction. And so if somebody has ureteral obstruction with elevated creatinine, you have to alleviate that. Because when we're doing chemoradiation, or if we're doing only systemic chemotherapy, understanding that platinum drugs are exclusively renally excreted, we need to make sure that we address that. Now, interestingly, there are data, albeit retrospective, and it's important to treat ureteral obstruction because patients live longer. So you have the capacity to place a ureteral stent or a nephrostomy tube and alleviate that pressure. Patients actually have a markedly improved progression-free survival compared to those who do not. So treatment completion is a secondary issue, but a very important issue. So multiple studies have shown that once you initiate radiation therapy, you have to have it done within 56 days. If you start prolonging the amount of time that it takes somebody to have the radiation therapy, day over day, you will see worse outcomes in their survival. It's also very important that the patient undergoes intracavitary brachytherapy, so they have to have the internal device placed to deliver that iridium right to the cervical stroma. If they don't do that, then you markedly increase the risk for recurrence. In the United States, what we're seeing often in the community when they're not around a tertiary care center and people aren't as familiar with brachytherapy is that they're doing what's called an external beam boost. So it may deliver the same amount of radiation, but the outcomes are not the same. It's also very important to realize that delaying throughout the course or delaying how long between external beam and radiation therapy again translates into survival changes. So one of the things that we talk about with the patients when they get initiated on therapy is they have to come. They're going to get tired, they're going to feel sick, but they have to show up. Cervical cancer, even in a locally advanced stage, can be a curable disease with chemoradiation, but they have to be compliant with the treatment regimen. And so this really kind of underscores addressing some of the social needs and social determinants of health, be it childcare, transportation, food insecurity, housing insecurity, and very often it just requires asking the patient about those things. So, treatment completion can be interrupted by a number of things that we experience, as I'm sure you experience. So, radiation oncologists don't treat on the weekends or on holidays. If the machine goes down, because that happens to us too, then nobody gets their treatment while the machine's down. And if it takes a while, then you're introducing kind of system delay. There are radiation side effects, there are chemo side effects. So if somebody has profound nausea, they have bad diarrhea, if they're getting dermatitis, sometimes these things require hospital admission, then you need a radiation break to be able to treat the side effects before you're able to reinitiate. Again, travel and transportation, childcare and home responsibilities, competing priorities. Like we have people who like, how am I supposed to work? Because if they don't work, they lose their medical insurance and then they can't get their treatment. And so a lot of financial toxicity issues that we see are very prominent in patients with cervical cancer, who at least in the United States are more often than not of lower socioeconomic status. One of our other fellows, Dr. Tagruyo, published in 2021 factors associated with the completion of intracavitary brachytherapy. And not surprisingly, white race, English and Spanish speaking, patients who are younger, and those who have private insurance. Basically those who've got all the opportunity to easily communicate with the system are those who are more likely to complete the treatment. So special considerations in this population as we kind of wrap up. So we know that there's side effects to everything we do. And unfortunately, cancer treatment can sometimes be considered a gift that keeps on giving. So we know there can be radiation fibrosis and vaginal stenosis. So we educate patients about using vaginal dilators to make sure they don't have complete agglutination. For those people who are treated with intact cervix, it's very important for us to be able to look at the cervix and evaluate it because they're going to be at high risk for recurrence at that point. If the vagina completely agglutinates in sclerosis, we're not able to evaluate that. Fistula is a very common thing, especially when you have bladder or rectal involvement with the tumor following radiation. Because the radiation field is inclusive of the entire pelvis, there are some areas, for example, the terminal ileum, which is anatomically fixed, which is going to be increased risk for stenosis, but we can see small bowel and rectal obstruction. You can get chronic irritation of the mucosa of the bladder and the rectum, and so longitudinally having rectal bleeding, hematuria can be something that we see commonly. Lymphedema, especially if somebody had a lymph node dissection prior to getting their chemoradiation, or they needed a radiation boost where there's lymph node involvement. And so then you've got a patient who now has a markedly enlarged life, and when we think about years of quality of life, the ability to work, this can be really detrimental to their life. And then Kathleen Schneider and MD Anderson published probably about 10 years ago pelvic insufficiency fractures. So within the first 2 years after completion of chemoradiation, 32% of people will develop, may not be clinically significant, but they will develop pelvic insufficiency fractures. And so it's very important that when you have patients who are potentially more frail or malnourished, that you're counseling them about weight-bearing exercise, which is just walking, or making sure they're getting whatever dietary supplements. And we've started doing actually bone density cements in these patients, even if they're premenopausal. So in summary, delays in treatment start and timely treatment completion are incredibly complex. But it's very, very important that we get radiation done within the first 56 days after treatment initiation. So anything you can do to avoid treatment delay, but also avoid delays after treatment initiation is very important. And then the long-term side effects of cervical cancer are important for survivorship care. These patients will come for a long time after their treatments for surveillance visits, and so it's really important that we don't ignore the side effects and longitudinal issues that they may experience. Thank you.
you so much, Professor Matthew. You've helped us, you've helped connect us with the perspectives of challenges in patient care from the other side of the Atlantic Ocean. Thank you so much. I think before we take questions, we will now try to see if we can check the last two presentations as we are trying to see the possibility of rounding up this reconvening in the next couple of minutes. So the next presentation is going to be taken briefly over the next 10 to 15 minutes by Dr. Halima Muqaddas. Dr. Muqaddas is a renowned figure in the field of obstetric and gynecology. She is the current MD, National Obstetric Fistula Center, NIGI, and really, as we are all aware, currently transforming the institution. Ladies and gentlemen, permit me to invite Dr. Muqaddas to present a topic on relating gynecological cancers and fistulas. Focus on Northeast Nigeria. Thank you. While we are trying to get presentation by the on, I want to ask if Professor Armiao is here, ready, so that we can take up. Right. Ladies and gentlemen, permit me to invite Professor Aisha Armiao, the first female professor of psychiatry from the northern part of Nigeria, and also the first female to be appointed MD of a federal neuropsychiatric hospital. Now you are doing what you are. Let's go to email.
Good afternoon, ladies and gentlemen. I will align by the existing protocol. I was supposed to be the last to give the lecture. As usual, mental health, even in hospitals, are at the end of the hospital. But unfortunately, all of us seated here, in the last 3-4 hours, this discussion on cancer, how many of you did not have anxiety or stress with the mention of cancer? I don't think so, because I'm not in your mind. So, mental health is a specialty that is often not considered in medicine. But WHO defined health as a state of physical, mental, social, and psychological well-being, not merely the absence of disease or infirmity. Whoever you are, whatever you do, wherever you are, without mental health you cannot function. So it means that we need mental health in all spheres of life. Sorry, using this can be a problem for me. So I will go by, I'm not going to talk about everything, but I will just show the slides. Stress is one of the most prevalent causes of cancer, if you don't know. Chronic stress could come from any of the below: inflammation, sleep disorders, increased hypertension, and others. Mental health and cancer. There are several studies that have linked cancer to severe life events, anxiety, depression, insufficient social support, avoiding coping strategy. And because most people that have cancer, they avoid it, they deny it. And that's why I think some of us, especially in the medical field, come quite late. There was a meta-analysis which included 290 participants who were found to have work stress, which is a risk factor for the cancers below. And most of us here have work stress, especially in the last 2 years. And COVID was a significant pointer of the significance of mental health. Mental health causes cancer, oxidative stress, which will come from any of this, free radicals. They are circulating a large number in the system. We don't seem to understand that. And they could come from either endogenous or exogenous causes. The endogenous causes could be immune cell activation, inflammation, mental stress, you have been overworked and you are stressed up, you are not sleeping, you are not eating, and other things like that. Exogenous, which some of them we cannot really control, includes air and water pollution, but others like cigarette smoke, smoking, alcohol, heavy metals, all of this can cause free radicals. Then when these free radicals are produced in excess, they go very fast. And then they are faster, very fast, they can't be neutralized. So they become antioxidants and it can cause oxidative stress. So this is what we should know and understand. Mental health, of course, oxidative stress, it has been implicated in depression, but what we are talking about specifically now is cancer. So it has been implicated in cancer. And cancer initiation and promotion are associated with chromosomal defects and oncogene activation induced free radicals. These free radicals are very common, especially in people with Alzheimer's disease. These are the impact of cancer on mental health. About 40% of cancer survivors will come down with this. Grief-related function, post-traumatic stress disorder, the person or close relative, because we should understand that the issue of cancer is not about the patient. It's even about the caregivers, the health professionals that are working with them. You see them in and out. And some of them, you know, they will not go out of it. You know, but you are managing them. So even that stress on its own too can predispose you to a mental health challenge. These are other things that will result from cancer, cognitive problems. Due to the medication, due to the chemotherapy, due to the radiation therapy, a person can come down with memory problems, executive function could be impaired, attention, processing speed, and this is what we call cancer-related cognitive impairment. While I was in June, just before I left, we had the consultation liaison psychiatry, which is a branch of psychiatry in the interface between psychiatry and physical illness. So we go to the oncology unit and we provide support during palliative therapy especially, and when breaking the news of cancer. What we do is we just tell them we have a cancer. It's not nice. We have to know how to tell them because it's a life-changing event. Psychosocial mobility in cancer, I have mentioned them earlier. All this could be found. Depressive spectrum disorders, I wouldn't discuss that. Anxiety disorders, I wouldn't mention that. And we have some symptoms of cancer phobia, which are listed there. Panic attacks, irritability, dry mouth, troubling. Some patients refuse to go for chemotherapy because of the side effect of chemotherapy. And nobody tells them what chemotherapy is. Nobody explains to them. We just subject them to that. So at least we should be able to explain to them what they are going to go through so that at the end of the day, they can have a respite after all said and done. Trauma, stress-related issues, neurocognitive disorders, which I had mentioned, they can come down with mild cognitive impairment. They can come down with delirium. For instance, while I was in June, most of the patients with delirium, they call us to manage them. Because once they start exhibiting some psychotic-like features, they call us to come and see them. Sexual dysfunctions, somatization, other psychosocial and significant disorders, all these are seen. Where I want to really talk is this need for collaboration. This is a patient who has an ovarian cancer. She is right yet, just a name. She has a cancer. What are the neighbors talking about? Ralia is cursed. Cancer is highly communicable. Her children are cursed. We won't worship with her. These are what the neighbors will say about Ralia, just because she has ovarian cancer. The husband will be thinking of, we don't have sex anymore. I will be a widower. Where will I start from? Those are the thoughts of the husband. Ralia, on the other hand, is thinking about her life coming to an end. What will she do? How can she live? What can she do? She goes into alcohol, she goes into drugs. While her children are wondering, if my mother dies, what will I do? Is there any treatment for that? And finally, the boss is saying, Ralia is not at work, so I'm going to give her pay. Why is it that she didn't come to work? All these are happening to one single individual. I just brought out this as a need for us to collaborate while managing patients with cancer, and even in the advocacy for cancer prevention. Now, this is the target. The cancer strategy is a proactive and reactive measure. The P stands for physical. They need to have physical treatment, which is the food they eat, the non-psychotic substance, the hydration, the vitamins, and the exposure to the sunlight. The affective is the A. That's where these free radicals are. What do we have to do? We have to avoid stress. We have to avoid distressing ourselves, especially the hypothalamo-pituitary-adrenal axis, which is implicated in stress. Then the C is the cognitive area. What do? We need to have psychological flexibility, health literacy. We have to explain to them what is going on. For those that are delirious in the evening, we need to let them know because it is worse in the evening. For the environment, all the exogenous things that would cause that, we should also have tips for them that they can sit, the kind of chairs they will use, logistic assistance in going to the market and other things they cannot do. Hearing aids, because some of them have tinnitus due to either chemotherapy or the radiation therapy. And finally, relationships, social support. Social support is very important in people that are ill, especially when they have cancer. So what at the end? What prevents depression and anxiety also helps to prevent the management of cancer. Good nutrition, reducing inflammation, improving mood, and social support. The aim is to get the mind and the body to work together. Help people live healthy and happy by preventing emotional and situational distress that can contribute to oxidative stress and activation of the HPA axis, which contribute to anxiety and depression. This is my conclusion. And while treatment, we have the oncopsychopharmacological treatment, where we use either the SSRIs, serotonin selective reuptake inhibitor, or the noradrenaline selective reuptake inhibitor in the management of this patient. So at the end, cancer has significant psychosocial consequences. Today there are scientific evidence which are evidence-based, including mental health in the management of cancer patients. The significant advances in research in the area of psycho-oncology have favored the development, implementation, dissemination of psychosocial guidelines, and evidence-based treatment for several comorbid psychiatric disorders in cancer. Collaborative care is evidently the pathway. So we need to have collaboration with you also. Thank you very much, and my
Very exciting presentation by Professor Aisha. So at this time, we will now take our last presentation, which is going to be on connection between gynecologic cancers and fistula by Dr. Halima Perez.
I think I must take 2 minutes out of my presentation to lay emphasis on some of the things that my sister Aisha said. Actually, that scenario that she presented actually happened in my center some few months ago. I have a staff who have not reported to work after her annual leave. So for 2 months she was absent. So we decided to give her a query and stop her salary because we need an explanation why she was not coming to work. Then the next thing that her relative brought, a medical report from Teaching Hospital Zaria, but those 2 lines saying that she's being managed for a serious medical condition. Who gives a report like that? Of course, when I saw the report as the boss, I said, no, this is fake. I'm not going to check it. So later the family came and then narrated that they don't actually know what is wrong with her. They have taken her to the psychiatric hospital and she's been evaluated for psychosis. To cut a long story short, she actually has advanced cancer of the cervix. And instead of that scenario to be presented in a proper medical documentation, to save her all those, she lost her salary for 3 months. Every relative, every member thought she has a psychiatric illness. So it's actually very important. Mental health, very, very important thing. Right, so thank you, and I'm not regretting giving you my slots. I can be last. I'm going to talk about creating gynecological cancers and fistula. Yes, sir. Is this still responding? Yes. So this is my outline, but most of what is in the outline has actually been discussed today. So I'm going to brush through some of it. We already know that gynecological cancers are these different types of cancers. And cervical cancer for us in Nigeria is second to only breast cancer. And we also know that in Nigeria we don't have a tailored, we are supposed to have a cervical cancer policy, but the implementation is problematic for various reasons. We have heard from the President Cancer Society and all the different problems that we are facing in terms of screening. But up to now, opportunistic cancer screening for cervical cancer is what is being used in most regions of the country. This is National Obstetric Fistula Center Ningi. I just want to give a little background of the hospital. These are my patients. This is after their surgical repair of fistula. That's why everybody is looking bright and radiant. I don't want to share the picture when they present. Usually that's the picture that you are conversant with. We prefer this one. So in National Obstetric Fistula Center Ningi is a public hospital that is dedicated to obstetric fistula repair and pelvic floor repair. It's a regional center in the Northeast region. And at NOFIC, we manage obstetric fistula. We actually conduct about 10 to 12 surgeries every week. That is our routine surgeries. Apart from that, we have what we call full surgical campaign, where we manage 50 to 100 patients on a quarterly basis. So that is how common obstetric fistula is in this region. So young girls and women that present to the center are usually poor. Most of them marry early or have their first pregnancy early, and most of them presentation is due to delayed obstructed labor, where they present with obstetric fistula, and then of course in 99% of cases, or should I say 99.9% of cases, the fetus is already dead. So the age of first marriage is often used as a proxy measure for early age at first intercourse. So what it means is that these young ladies have been exposed to sexual intercourse very early. This has been linked to increased risk for development of cervical cancer. But we already know that fistula, when we say fistula in gynecological oncology, most of you will think towards Dr. Matthew's presentation, where we see fistula as an uncommon complication occurring following advanced malignancies. This is not the fistula and disposal. This is the fistula and disposal that is related to childbirth, usually occurring between the bladder, the vagina, or the rectum. So it could be either vesicovaginal fistula or rectovaginal fistula. For this presentation, we conducted a scoping review, and we developed a science strategy to identify relevant literature to see from empirical data what has been done in terms of opportunistic screening for cervical cancer and fistula in Nigeria. Unfortunately, I could only come across one study that have actually addressed that. All the other studies we have reviewed, research was mainly conducted, and we found 41 documents where we analyzed, but most of them were systemic review, scoping review that essentially cut across the low middle income countries, not Nigeria specifically. And we have 4 cross-sectional and 2 exploratory studies. From the review, it was clear that most of the opportunistic screening that was done was that for HIV, and some were for family planning, but none was for fistula, obstetric fistula in particular. However, we are aware that in 2020, there was a pilot study that was conducted, but not other than Dr. Lamaran Betizo and the VC of this center, where they, over a 6-month period only, they were able to screen 98 women. And from these 98 women, they found a significant result, especially of the low squamous intraepithelial neoplasm among these women in National Obstetric Fistula Center. So this is showcasing that there is a huge gap that is actually not being studied in the Northeast, or should I say in Nigeria as a whole. So the opportunities have been presented. I think we need, in summary, we need to use that opportunity to study patients with obstetric fistula. We have over 14 VVF centers in the country. We have 3 national centers. I think we can do a cross-center study to actually provide the necessary care for these young ladies that have been exposed very early to sexual intercourse. And one beautiful thing is, across all these centers, care is provided free of charge for the patient with obstetric fistula. So it will not cost much to actually include screening for cervical cancer among these patients. The second thing, so it is feasible and there is access. These women of necessity must come to those various centers, because if not, they will stay and they will continue leaking urine. We know that in 90% of cases, the management is surgical. And it is cost effective, because we are still seeing late presentation of cervical cancer in our environment. So if we can catch them before they have the late stage, I think it will be cost effective for the treatment of these young girls. So this is our future agenda for the National Obstetric Fistula Center. For obstetric fistula, we want to make sure that we present, together with urodynamic studies, the epidemiology and the evaluation of the different types of fistula before and after repair. We want to also undertake clinical trials of the different surgical techniques and treatments that we're offering. But for this presentation, this is the third point that is very important. Opportunistic and organized screening of cervical cancer is of necessity in these young, vibrant, sexually active women. Because I think it's good, the adage that say we catch them young, it should be applied to them. Thank you very much.
Thank you so much. That was a very beautiful and excellent presentation by Dr. Mukaddes, connecting gynecologic cancers with fistula and focus on fistulas in Northeast Nigeria. So, ladies and gentlemen, at this point, we are coming close to the end of this event, and I would like to announce that soon we shall have group photograph, and before that, we are going to have presentation of plaques to the speakers and moderators by the letter, right? And we shall also have a courtesy visit, but our team from Miami are going to visit one of the ancient traditional institutions in West Africa, that is the Qatar Emirates. So we do believe we are going to have an exciting moment in the area of Karabo. And we are going for lunch.
Okay.
We have a photograph here now.
Thank
All
you.
presenters, all moderators.
All presenters and moderators will have a group photograph with the questions. With the authority of the Vice Chancellor, the chairman of the occasion today, after the visitation of President there will be lunch and the prayer. So during the lunch period, I'm directed to tell all